They compared outcomes between pregnant women or pregnant persons who received buprenorphine treatment during pregnancy and pregnant persons who did not. And the findings of this study, my God, it is powerful. They matter for anyone who is working in addiction, you're working in psychiatry, you're OB-GYN, family medicine, pediatrics, public health, policy. It is powerful evidence, because what does it show? This opioid use epidemic, we know there's an epidemic. Hello and welcome back to Transformed Minds, the podcast where we explore the real world intersections of mental health, addiction, and transformative care. I'm your host, Dr. Owusu. Don't many know me as Dr. O, and you can call me that too. Each episode, we take a very thoughtful and practical an evidence-informed look at how we can improve psychiatric and addiction care from clinical settings to our community spaces. Today's episode is a Host RX, and I'm glad you are tuning in. If you're here, here's the vibe. So with Host RX, it's just me and you, breaking down the research, sharing what actually works for us and our patients. Expert RX brings in brilliant minds from the field, clinicians, researchers, change makers, anyone who is an expert in the field of psychiatry and addiction. We welcome them and we have a conversation. And Lived RX, that's where real life stories come in. Guests who have lived it, survived it, and are reshaping the system because of it. They are the core to Transformed Minds because they have experienced it. Today, we're focusing on an area of substance use that don't really get nearly enough attention as other things, right? Opioid use management in pregnancy. How do we treat opioid use in pregnancy? We will be breaking down a very large retrospective cohort study from the Tennessee Medicaid that recently came out in JAMA this year. And the study followed over 14,000 maternal infant pairs from 2010 to 2021. The study is called Buprenorphine Treatment in Pregnancy and Maternal Infant Outcomes. The researchers, please forgive me if I said your name wrong. Call me, correct me. Krishnapura, McNeer, and Loch SR, they compared outcomes between pregnant women or pregnant persons who received buprenorphine treatment during pregnancy and pregnant persons who did not. And the findings of this study, my God, it is powerful. They matter for anyone who is working in addiction, you're working in psychiatry, you're OB-GYN, family medicine, pediatrics, public health, policy. It is powerful evidence, because what does it show? This opioid use epidemic, we know there's an epidemic. There's opioid crisis. And opioid use disorder in pregnancy, it's very high stakes. And it's a real public health challenge. Why? Because it's pregnant women, right? You're not just treating one person at that time. Now it's two people that you're treating. So without treatment, you get very poor prenatal care outcomes. You get very poor prenatal care engagements, very higher overdose risk, and poor babies, but even poor mothers, poor families who are now experiencing whatever tragic situation that may happen to not just the mother, but also a fetus. So this is very important. Buprenorphine is one of the gold standards of medication-assisted treatments, yet it is very underprescribed in pregnant persons. And this is mostly due to stigma, lack of provider training, and myths and misconceptions that surrounds the safety of it. So today we're going to be myth busters. We're going to come and address the misconceptions, and we're going to look at the efficacy and what the evidence shows for using buprenorphine in pregnant women. So what happens when a pregnant person with opioid use disorder receive buprenorphine? That's exactly what this study sets out to explore. So let's see what the researchers found. So the overview of this study, like I mentioned, is a retrospective cohort study. And they used Tennessee's Medicaid claims data from 2010 to 2021. So that's about 11 years of data. There's over 14,000 maternal infant dietats that they looked at, and they grouped them into two groups. So pregnant persons that received buprenorphine versus pregnant persons who did not receive any medication-assisted treatment. And they looked at what are the outcomes, what are the key findings, and this is what they found. They found that 51.6%, so almost 52% of pregnant persons received buprenorphine in this cohort. And adverse neonatal outcomes occurred in only about 25% of the group that received buprenorphine versus 30.8% in the group that did not receive any medication-assisted treatment. So 25% neonatal adverse effects or adverse outcomes happened in buprenorphine group versus non-treated group who was 30.8% of neonatal adverse outcomes. So this is very big. So there's at least a 5% difference where there's 5% of cases that adverse neonatal outcomes could have been prevented if pregnant women, pregnant persons received buprenorphine treatment. So what happened? Let's look at the detailed findings. They found that the buprenorphine group had lower preterm birth rates. So it's 14% in the buprenorphine group versus 20% in the non-medication assisted treated group. The group that received buprenorphine had fewer NICU admissions, reduced small for gestational age risk, lower severe maternal morbidity. And this shows, so for fewer NICU admissions, it's about 15.2% to 17.2%. So at least a good 2% difference between the buprenorphine group versus the non-treated group. And then for reduced small for gestational age risk, it was 7.5 to 10.6. That is a 3.1 difference, right? 3.1 risk difference. And then for lowest severe maternal morbidity, it was 5.4 versus 6.9 in the non-treated groups. So these are just not numbers. It's statistically significant and it's clinically impactful. It's clinically significant as well, right? Because we're looking and we're saying, these are babies who could have had better outcomes if the parents, the person carrying them, received treatment, right? All they had to do is receive treatment and it could have given them better outcomes. But without that, poor babies, they're coming out with lower birth rate, more NICU admissions, more small for gestational age risk. They're higher risk for that. And the mothers themselves have more severe maternal morbidity. So these are things that we could present. This is why studies like this matter, is to show and, mitigate whatever misconceptions that are out there, because people are concerned with the safety of it. It's not, it's going to hurt my baby if I receive it. But this is a study of over 14,000 pregnancies over 11 years, actually showing that no, your baby actually has a better chance. And you yourself as a birthing parent has better chances of, not getting any sort of illness, not losing yourself or losing your child, right? And there's like such a huge growing body of supportive evidence that supports buprenorphine safety and efficacy in pregnancy. And this is already affirming what many clinicians, many physicians in the field knew. But when there's not evidence supporting the things that we're saying or, clinical experiences, sometimes it could be a little bit tricky to convince people, right? So when we have the data to back up things that we already know, it's important. And we already know that treating opioid use disorder in pregnancy is not just optional. It's not supposed to be something that's optional. It is life-saving, right? So it could save a child's life. It could save a mother's life. Buprenorphine, we know, lowers maternal and neonatal risk, right? So it's important. Early access, consistent care, stigma-free settings are very key to providing these services and treatment for mothers and pregnant persons. It also raises questions about equity, right? Why are nearly half of pregnant patients in this Medicaid sample still not receiving treatment? What could be going on? Like, what are some of the barriers that is holding people back? What are some of the barriers that is causing this gap in treatment, right? So if you have not yet listened to the prior episode with Dr. Bo, please go listen to that episode. She is an expert in, and a director of a system that cares for over 45,000 people for free. Provide them services, addiction, integrative care services for free, right? And she talks about what are some of the barriers in our system that we can help mitigate as providers, as students, as trainees, as experts, as family members, right? What are some of the things that we can do as policymakers to mitigate these barriers? So please go listen to that episode if you haven't listened to that episode yet. So what are some clinical pearls from this study? For providers, here are some of the key things to take away from this study. Initiate treatment early. Start buprenorphine early in the pregnancy. The earlier you start it, the better the outcomes. Co-manage, right? Remember, I just talked about integrative care, collaborative care. You have to link the obstetrics care to the psychiatric and addiction services that the person is receiving. There are multiple studies out there showing this actually increased compliance if you link it, because there's such stigma associated with addiction care. When you link this in a collaborative setting, people are more likely to show up for their appointment. People are more likely to come to treatment. And there are multiple evidence-based studies out there showing this. So co-manage, right? Educate. Counsel your family, counsel the patients, teach people, even your colleagues, clinicians who may not be experts in the field, teach them, right, to reduce the stigma. We know buprenorphine works, and here's the studies, here's the evidence. We know buprenorphine does not harm the baby. Actually, not giving it is going to cause more harm than giving it, right? So give the buprenorphine, protect the baby, prevent worse outcomes. That's very important. And monitor adherence, right? Use very flexible dosing and make sure it's a collaborative effort between you and the person you're treating, right? This is a shared decision making, right? The person you're treating is at the core center of that treatment plan. It's not you, the provider, it is the person that you're treating. So it has to be a collaborative, shared decision-making effort to make sure the person is adhering to the treatment you're providing them. Address the stigmas, like address the elephant in the room. Don't beat around the bush. Many pregnant patients avoid care due to judgment because they think someone is going to call CPS on them, someone's going to take their baby away, you're going to judge them. Address those stigmas, right? Address those concerns so they know, it's important to get treatment. It's important to make sure you're getting the appropriate treatment for yourself and for your baby to make sure that you're given, both better outcomes, better chances at, better quality of life. It's very important. And make sure that medication-assisted treatment access is also harm reduction, right? You're educating that harm reduction includes replacement therapy, and buprenorphine is a replacement therapy, and it's important, right? Make sure there's more access to that because, again, as the study is showing and other studies have shown, it lowers preterm birth rates, NICU admissions, and maternal morbidity. Safe postpartum transition, right? So make sure you're considering long-acting injectables options for stable maintenance after delivery. So after someone delivers the baby, make sure you're providing them with the appropriate maintenance care. You're not just leaving them just like that. There should be a continuity of care for the persons after they transition from, having the baby, their postpartum, perinatal. So make sure there's that continuity of care in that perinatal time frame. And even beyond that, because you want to make sure that you're maintaining treatment, that you're providing support for this person at any point in their lives, whether they're pregnant or not. But I do recognize this is about pregnant persons. So what do we need to change? I recently did a project that focused on maternal substance use. And a lot of the studies I actually looked at show that there is this gap in comfortability and confidence amongst providers to treat pregnant persons that use the substances. So some of the things that we really need to change is broader training in obstetrics, gynecology, family medicine, psychiatry, emergency departments, internal medicine. They don't really see pregnant persons, but any provider that's caring for a child or a pregnant person should get a broader training in what to do, how to manage some of these things, because right now we have a shortage of doctors, right? That's we know. But even beyond that, we have a even greater shortage in specialties, right? And specialty care. So people have to wait for long periods, 2 weeks, months for specialty care. So knowing something basic knowledge about how to manage some of these things, the collaborative care, all of that is important to cut down those wait times, make sure people that are ready and want the treatment, the treatment, right? The access to that treatment is there when they're ready. Because trust me, there are people that may not be ready, and there's that fluctuation in the readiness of a person to readiness to change and all of those things. So if they're ready and then the access is not there, by the time the access comes, they may have changed their mind, or pregnancy lasts 9 months. They may have already had the baby. So let's make sure that we have these access, we have the broader training, so almost everyone can help, assist, and give care in these cases. So policy protections is another one against criminalizing substances in pregnancy use, right? So there's all these rules. And one that I examined actually in a few states throughout my project was the Good Samaritan law. So we all know the Good Samaritan law that's out there, but there's a different kind of Good Samaritan law about substance use, where if you come across someone that's overdosed or any of those things while using substances, you can call help for them and they're not going to get in trouble, or they're not going to get arrested, any of those things legally. But there are caveats to that, right? There's like a caveat to all of this. I believe in Texas, even in New York, it's really dependent on, let's say you're not on probation, you don't already have a warrant out for your arrest, you don't have like when the police come, you don't have a certain amount of substances on you. If you have a certain amount of substance on you, that rule, kind of like the Good Samaritan law, is sort of out of the window, right? So you have to look at the limitations of all these rules and laws. So like if we have policies that actually protect against criminalizing substance use in pregnancy, and we move towards more rehabilitative care, right, where we're providing supportive services, assistance, harm reduction strategies for these people. There's evidence out there that's showing that reduces the amount of substances that people are using. It reduces poor outcomes more than criminalization. So why don't we move towards that? Why don't we move towards policies that are protective instead of putting people behind bars or taking babies away? There are times where those things may be appropriate, but I don't think, and I do not believe that should be the first step. We should try, rehabilitative processes, restorative processes for these people. There's so many programs out there now. There's so much evidence that's out there. Let's try to implement these. Let's try to use these for sort of protect the mother, the baby, and all of that. Because a healthy mother, healthy baby, right? Mentally stable mother, mentally stable home, mentally stable baby. So we have to make sure we're providing like better quality of care and better outcomes for people. And more lower barrier access points, right? Mobile clinics, free clinics, telehealth, urgent care partnerships. I was so excited when I was in DC and I had the chance through my fellowship with SAMHSA and the APA, I had the chance to tour the District of Columbia Behavioral Services and noted that they have an urgent care service for psychiatric. They have urgent care psychiatric services, right? This is important because not everyone needs emergent psychiatric care, right? And one of the centers that we visited, one of the physicians, psychiatrists, there was actually an addiction fellowship trained, board certified addiction psychiatrist. So imagine having that kind of access where you can go for urgent care, urgent services, right? It's amazing. And I feel like these are things that should be replicated across the nation because it's like you're moving towards more like low barrier cares, right? And we know how urgent cares operate, right? You can just walk in at any time, any moment, and get those services. And there's that continuity of care where they can then link you to services beyond that. So after they see you, they could give you a referral to a clinic or somewhere else, but at least they've started you off. So for instance, imagine you have a pregnant person that's ready for treatment, right? She's ready. She wants to start this treatment. Walks into the urgent care. They've been waiting for like 2 weeks. She called a clinic and they're like, well, you have to wait 2 weeks, but there's an urgent care in your state. So she goes into the urgent care. There's a specialist there. She gets started and gets at least a 2-week supply of her medication until she's able to get an appointment with an outpatient provider. Look at that. That's a low barrier access care point. You have provided access for someone whilst waiting, right? And they know, like, in that 2 weeks, if they don't go to that appointment or something happens and they lose that appointment, they could come back to the urgent care and they can reconnect them with services. And these things are very important. We do this similar for benzodiazepines or controlled substances, right? In emergent cases, in the state that I work in, if a patient has an emergency and they can't get their refill, right, they can go into an emergency room. If there's an emergency psychiatric room, medical, they could go and they could possibly, like there's a system where you could check to make sure, it's not being misused and all of that. So the person then goes and can get the refill until their next appointment. Like I've had patients who would go because something with insurance, there's a lapse here and there, but they could go to the emergency room. They receive, let's say, 7-day supply until their next appointment with me. So they don't have to wait. They don't have to lose. So why can't we do this for other things like buprenorphine and all these substances that we prescribe for people that are misusing substances that needs our help and are ready to change, like pregnant women, right? So for our next segment, let's talk a little bit about a case. I know I just gave you like a pre-case, but let's talk about a case now, okay? So let's talk about a case. This is a 26-year-old woman, gravida 2 para 1, at 10 weeks gestation, presents to the OB clinic for prenatal care. She reports daily heroin use over the past 2 years and recently started use of fentanyl unknowingly. She's ambivalent about treatment and fearful of losing custody of her child. What's your initial approach? What have we talked about? Non-judgmental, right? And it should be a trauma-informed conversation, especially if this person has a history. So if you look, it said she's gravida 2, para 1 at 10 weeks, and she came in, right? She's using heroin. She's fearful of losing her child. You have to make sure it's a trauma-informed conversation, very non-judgmental, and the easiest thing you can do. I know one of the questions in the prior episode where we talked to Dr. Bo, we asked her, if I was a small clinic or I was running a small clinic, what would be one advice that you can give us to mitigate barriers? And the first thing she said was screening. It's easy. Anyone can do it. Literally, that should be one of your initial approaches. Create a non-judgmental, trauma-informed approach and screen, right? Screen. There's all these screening out there. Use them. Screen using the DSM-5 criteria. And then do a brief counseling on buprenorphine safety and neonatal outcomes, right? Because there's that fear there. So show them what the evidence, like this study that we just went through with the Tennessee Medicaid program, it shows that there's like low outcomes, and there's not that those safety concerns that people may have that, you know, the child are going to have worse outcomes. That's not there. So share that, you know, counsel the person, their family, so they know. And then come up with a collaborative care plan, right? Initiate buprenorphine after shared decision making, after that psychoeducation, link, right? What do we say? Like co-manage. So link that addiction service, link that treatment plan to the OB program or the OB services, to the medication assisted treatment. Make that integrative care. If there's a chance where the person can go to the same clinic and receive both treatment, give them that option, right? It reduces the stigma, it increases compliance. And what do we want? Compliance. We want people to take these medications. We want them to do well. We want them to go to the therapy. We want them to take their prenatal vitamins. We want them to do the things that would give them and their child better outcomes. So provide that for them. Provide harm reduction education and supplies. Provide them naloxone, right? If someone has opioid use disorder, it's important to provide them naloxone and teach them how to use it. So again, I'm going to refer you to our other episode on xylazine, where we talked about how to properly use naloxone. Go listen to that. Get you some pearls from there. Okay. And then discuss delivery planning and postpartum follow-up. So what's the follow-up plan? Once you're done, this doesn't end here. We want you to continue to follow up. We want you to continue seeing your OB. We want you to continue seeing your addiction specialist or your psychiatrist or your primary care provider, whoever is treating you. We want you to continue these treatments, right? It does not end here. And then outcomes, right? Throughout your entire trimesters, all of that. Discuss the outcome goals of the patient, treatment goals. We want safe pregnancy, safe delivery, healthy termed infant. Observe the infant for neonatal abstinence syndrome. But if they did not require treatment, right, that's fine. But at least observe the baby to see, is there the possibility? It's not going to harm a fly. Just observe, right? We always wait and watch. Just observe the baby and see if there's some signs there, if they're going to need treatment. And then long-acting injectable again, postpartum, you know, there's the long-acting injectable, give it. Have that collaborative plan, shared decision making. Add this to it, discuss it, right? At least bring it up and discuss it. And then what have we learned from this case? We see that, you know, early engagement is important. Educating, compassionate care, kindness, non-judgmental treatment is very important. And this can alter the trajectory for both mother and baby. It's very, very important. So let's reflect a little bit on what we have learned so far, right? From this study, it's basically reminding us that providing buprenorphine to pregnant patients with opioid use disorder is not only safe, but is very essential. It's life-saving, right? It's a form of reproductive justice, if I may say, right? Harm reduction and maternal health equity. It's important. Give it. Right. So whether you're a psychiatrist, a pediatrician, obstetrician, gynecologist, social worker, medical student, trainee, wherever you fall in your training, in your career, just ask yourself, Am I comfortable discussing medication-assisted treatment in pregnancy? Is my team ready to offer coordinated care? What barriers still exist in my setting, and how can I break them down? Ask yourself these questions and take the steps to mitigate them, right? Take the steps to mitigate them. Thank you so much for tuning in to the Transformed Mind. I am so happy you tune in. I am so happy you're here to learn with me. It's amazing. And I love, 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 love doing this. I'm Dr. O, and I hope this episode helps you to feel more equipped, more empowered, more informed, and above all, transformed. Subscribe for more host RX breakdowns, expert interviews, and live RX stories. And check out the links in the show notes for full study and clinical resources. Until next time, stay ready, stay aware, stay grounded.